Today we are going to learn about internal medicine and pediatrics from Dr. Meredith Landorf, and she's with the UK College of Medicine at NKU's campus. And then next week on May 5th, we're going to have somebody here to talk about the graduate nursing program. That'll be Dr. Karen Vietz, and she's the graduate nursing program director for the doctorate program and the master's program at NKU. Dr. Landorf is going to share her presentation with us, and then if you have any questions throughout it, you can put it in the chat or unmute yourself and we'll make sure they get answered. So you can go ahead and take it away, Dr. Landorf, whenever you're ready.
Good morning. As Avery said, I'm Meredith Landorf. I practice in Edgewood with St. Elizabeth Physicians, and I do internal medicine and pediatrics part-time, and then the rest of my time, I'm the assistant dean of the new regional campus in Northern Kentucky. I'm going to share my screen. So I just wanted to kind of walk you guys through like what is Medpeds and what do we do and how do we get there. So the journey to the career in medicine is a bit of a long hike. So we do 4 years of college. You're actually able to major in anything you want to. So I think some people think you have to be a biology major to go into medicine, but as long as you do your medical school prerequisites, you can actually major in anything you love. And then we do 4 years of medical school, and that could be at an allopathic institution like UK or at an osteopathic institution like Pikeville College of Osteopathy in Pikeville. And then after medical school, you do 3 to 5 years of residency, depending on what specialty you choose to go into. And then you have the option to do fellowship after that. So it's kind of hard and fun to think about the fact that like your kindergarten through high school is the same amount of time you'll spend going from college, med school, and residency. So what do I need to do if I do want to apply to medical school? So what does those college years look like? And I just brought in kind of the most common prerequisites that most medical schools use. And basically it's a lot of science, which isn't surprising. So most places require 2 semesters in physics, 2 semesters in biologic sciences, 4 semesters in chemistry, and it has to include organic for most schools. And then 2 semesters of English. Some schools still require a semester of calculus as well. And most medical schools will count some of your AP credits if you have them, but typically you have to take physics even if you took the AP exam. So you have to have a bachelor's degree, but again, it can be a Bachelor of Science, a Bachelor of Arts, or a Bachelor of Fine Arts. They don't care which one. And then we do take the MCAT during junior year of college. Think of it as kind of like the med school's ACT. So how did I get here? I was actually an environmental engineering major at Murray State University. I took my MCAT during junior year, like everyone who was pre-med. And then I applied to about 7 or 8 schools. Life was really different back then. I'm kind of old. So we didn't have Google. We didn't have the internet. You requested things out of books on paper and we filled out applications. We did have computers and printers. So you sent everything in on paper, which is so different than now. But it also kind of limited the amount of schools you could apply to compared to how things are these days. I received 3 invitations, and I interviewed at all 3. And then I was accepted to 1 medical school, and then I was waitlisted at 2. I did end up getting offers from those other 2, but I had already decided I was going to UK. So I went to the University of Kentucky College of Medicine in Lexington, and I graduated in 2001. And then after medical school, how you decide where you're going for residency is actually a little cross between like job application, school application, and speed dating. So you apply to residency based on what specialty you want to do. By this time, we did have the internet a little bit. So a lot of this was done that way. And then they offer you interviews based on your residency applications. And that's the part that's a little bit like speed dating. So over the course of 3 months, we visited about 20 different residency programs and interviewed. And then you submit a rank list. So I couples match with my husband, who is also in medical school. So we basically said our first choice is to go together. And so if we didn't match together, they would go to our next choice. But you rank all the schools that you applied to, interviewed at, and liked in order. And then the residency programs also rank all of the applicants that they interviewed that they'd like to match their program. And a computer runs all the iterations to put everybody in their highest choice and the school's highest choice, so that everybody's kind of like optimized. And then usually right around St. Patrick's Day, your class gets together and you open your envelope and read where you're going for the next 3 to 5 years of your life. I matched at the University of Rochester Strong Memorial Hospital in Rochester, New York, for our Medpeds residency. So what exactly is Medpeds? So Medpeds is a combined residency program. So it's internal medicine and pediatrics. So if you went into internal medicine alone, your residency is 3 years. If you went into pediatrics alone, it's also 3 years. So Medpeds basically takes those 6 years and combines them into a 4-year residency. And how that works is really that a lot of your electives count for both. So like when you're on pediatric endocrine, it's still counting for an elective towards medicine. So you do all of the same core, like hospital wards and ICU rounds, but a lot of your electives kind of count for both, which is how they're able to compress that 6 years into 4. But when we're done, we do sit for both categorical boards, internal medicine and pediatrics. We are not our own Medpeds board, but we're basically a combination of those 2 categorical boards. But that also means we have to keep up our maintenance of certification, which is like our continuing education, both on the state level and for both sets of boards. And you have to recertify, which are those board exams every 10 years. The nice thing about Medpeds is we can see everybody. So we see patients of all ages, really from birth through death. We can work in the inpatient or outpatient setting. So you can be a hospitalist who only works in the hospital. You can work just as an outpatient doctor, like the pediatrician you all are used to seeing, or a combination of the 2. We're also able to apply for any fellowships in pediatrics or in internal medicine. So fellowships out of peds and internal medicine are things like nephrology, which are the kidney doctors, or the pulmonologists, which are the lung doctors, or the cardiologists, which take care of hearts. There's also some interesting, what we call transition care, that many Medpeds graduates choose to do. And this is often like the kids who are born with congenital heart disease who have had repair. They actually will follow up with a transitional cardiologist who does peds and adult cardiology. Because as you can imagine, taking care of a 60-year-old who had congenital heart disease repair surgery as an infant will be a little different than just taking care of the typical adult. We also see some of these transition clinics with our adult cystic fibrosis patients and our adults with developmental disabilities. So there's a great niche that Medpeds really prepares you well for, to kind of take care of the transitions. But I also love that I can have patients who have like left their pediatrician because they've kind of aged out, but we still are kind of kid friendly. So I get a lot of college and graduate age students who come in who they're too old for their pediatrician at that point. But it's a nice transition to take care of folks kind of in that becoming adult phase of life. I kind of already talked about that. It talks about what the fellowship is. So what do I do? What do internal medicine and pediatric doctors do? So a lot of this are things that you all have already had experience with just by being a human. So a lot of my day, especially during kind of post-COVID or later in COVID times, is preventative care. So I do lots of well baby checkups, school physicals, college physicals, women's health visits, like adult well care, so kind of your grown-up well child check, and then Medicare and annual exams, which are kind of like the over 65 checkups. We also do sick care. This looks a little different in the COVID world. So I do a lot of these at people's cars at this point. So I go out to them instead of bringing them into the office. But typically, especially during the winter and strep season, it wouldn't be uncommon for about a quarter of my patients to be sick visits. These are things like sore throats, make sure it's not strep, urinary tract infections, I hurt my ankle, do I need an x-ray, that sort of thing. And then probably about 30 or 40% of my visits are for ongoing medical issues. So these are like my adults with diabetes or folks who have migraines that aren't controlled, or high blood pressure visits. So basically anything that somebody takes medicine for routinely, we tend to see them at least one extra time a year, separate from their well visit. And for some things like diabetes, we actually see them every 3 months. So I get to do some procedures. I'm not a surgeon, so I'm not like in the operating room. But we do things like drain abscesses, which are kind of like boils. I can aspirate fluid off of knees, or bursa. The most common bursa that we drain is actually like at your elbow. So folks will come in with this like big water bottle looking hanging thing off the back of their elbow, and we can drain that for them. I take out lots of foreign bodies. So like Barbie shoes in kids' ears, or hair beads up kids' noses. And then we also do a lot of developmental screening. So sometimes this happens during your well checkup, but sometimes we'll see kids in between if mom and dad don't feel like they're kind of meeting their milestones or keeping up with their peers. I'm going to unshare. So what questions do you guys have for me?
And you guys are welcome to unmute yourselves or put questions in the group chat, and we'll make sure it gets read.
So I actually started out as a I'll read the question. Why did you choose the career you did? So I started out when I left for college, I actually wanted to be a biomedical engineer. I wanted to design prosthetics. But I got to freshman seminar of college, and during biomed seminar, we put screws through a cadaver spine on this like machine that like flexed it over and over again. So basically you put the screws in and you waited all semester, and it flexed 24 hours a day. And you just waited for the screw to break. And I remember looking at my friend going, where are the people? And I think that was my moment of like, maybe, my calling is more to be with the people and not just, with the screw and the cadaveric spine. My friend in college who I said that to was actually pre-med, and I'm like, okay, sounds good. So that's kind of where I made that like change from I wanted to design prosthetics to I want to go to medical school. When I went to medical school, my plan was to be an orthopedic surgeon. So kind of in that same, helping folks, prosthesis. And I like project kind of stuff. Like me and YouTube can do almost anything in terms of, trying to build or fixing things. So all through medical school, I thought I was going to be an orthopedic surgeon. I loved ortho. I loved putting things back together. I kind of kid that it was like broke bone, fixed bone, grunt, and you could see very quick results. Like the bone was, put back in line, and you can see in the x-ray that it all looked good, and folks could get up and stand on things, days or weeks or months after, they were kind of crushed. But when I was doing my visiting rotation at Ohio State during my 4th year of medical school, my attending was Dr. Pugh, and his wife actually locked her keys in her car at soccer. And we were fixing a broken pelvis, and he just kind of told her through the OR phone, just get a ride home. We'll go get the car later. And it was kind of in that moment that I had, the light bulb of, I think I want to be a mom. I don't know that I can be a surgeon and be a mom and be married to another physician. So that night at the residence apartment, who was letting me sleep on her couch, I emailed one of my mentors from medical school, who is actually a pediatric infectious disease doctor. And I said, Dr. Nelson, I know like our residency applications are due in like 24 hours. I'm like, but I think I need to change my mind. I think I need to do Medpeds. And I actually kept his email back to me. It's in my like med school scrapbook, but it said, we're glad you figured it out. We've all known for a very long time that was kind of where I belonged. So, for me, I think I needed to kind of experience all of the pieces of medical school, and then also kind of settle in with where I really belonged. I think there was a little bit of kind of some pressure in terms of being a woman wanting to go into a male-dominated field like orthopedic surgery. I almost felt like I had to prove that I really could do it. And there's still a little piece of that like, because I changed my mind, and I don't regret that, there's still a little piece of me that, wonders, could I have gotten a residency spot? And I think that I could have. And could I have been an orthopedic surgeon? I think I could have, but just because you can doesn't mean you always should. So I do think that, in that moment in the OR, keys locked at a soccer game, it was really my opportunity to kind of accept the fact that, my brain needed to do a bigger part of my piece in medicine than just my hands. Yeah, could you explain being able to get a residency spot? So residency spots are like nationwide and they're limited. So some of it is based on like Medicare guidelines and kind of the national graduate medical education system. So you can't just make as many residencies as you want. Once you kind of start your residencies, they stay that way for your institution. And most residencies are at, larger teaching hospitals, but there are some community programs. Like St. Elizabeth has a family medicine residency. Christ has internal medicine and family medicine. Good Sam has family medicine, internal medicine, and general surgery. But then like UC has everything. So basically, once you've picked your specialty and you know what you want to do, that's when you start looking at who has programs. So back in 2001, when we were looking, there were about 30 Medpeds programs in the nation. I think we're up in the 50s now. So there's actually more spots than there were 20 years ago for Medpeds. And basically you think about, where do I want to live? Do I want to be in a big city? Do I want to be somewhere where the cost of living is such that I can buy a house? Do I think I'll have kids in residency? What is the school like? Daycare options? Do I like the residents? Back to the speed dating part, because these are the people you're going to kind of live with for those years of residency. So really, it depends on your specialty, how exactly you go about deciding where to apply. Some folks say, I really need to stay in the tri-state. And so they might apply, to multiple programs here. So they might apply to all 3 internal medicine programs, and they might also apply to the 3 family medicine programs. Because they say, I absolutely have to stay here. Where other folks say, I just need to stay within 3 hours of here so that I can drive home to see grandma. And if that's the case, we have Columbus and Indianapolis and Lexington and Louisville. So kind of how you choose where to apply really depends on your personal kind of priorities and your specialty. For example, like if one of my students currently, he's like, I really want to live in Colorado when I grow up. And there's like 2 programs in Colorado for what he wants to go into. I'm like, so we probably need a plan B. Like that can be plan A, but we really need a plan B. Residency competitiveness really depends on your specialty. So things like family medicine and internal medicine, there's over a 90% match rate, meaning people are matched with somewhere on their list. Where things like plastic surgery, like even if you're like the best of the best, there's about a 75% match rate. So if you're going into a competitive specialty, plastic surgery, dermatology, ophthalmology, radiology, it's good to potentially have a plan B depending on your grades and your board scores. Your advisor will help you decide, like, if you want to be a plastic surgeon, but you're kind of at the mean in terms of scores, they likely will encourage you to also apply for a general surgery residency, knowing that you could do a plastics fellowship later. For things like pediatrics and family medicine and internal medicine, and even like ER and OB, like the match rate is pretty good, up in the upper 80s, low 90s for most of them. So we just encourage people to apply to enough programs based on their scores and grades and things. Some of this is changing as med schools are going to pass fail. And actually the STEP exams, which are our kind of boards during medical school, those are also going to pass fail. So we think that a lot of the program directors will be using letters of recommendation more than they have in the past. It used to be that your STEP score was kind of the first screening, and then they'd start reading. And so after this year, we don't anticipate having STEP 1 scores anymore. It'll just be pass fail. And this is where networking, I think, can help you. So if one of your attendings, their alma mater, and you apply there, there's a good chance that they'll be like, oh, one of our alumni wrote this letter, let's take a look at them. And then it kind of comes down to the match. Now, if you don't match, it's not like the end of the world. We used to call it the scramble, and now they call it the soap. But basically, any programs that didn't fill, you're allowed to kind of scramble into those spots. There are also something called a transitional year, where you take a year doing your internship, kind of being undeclared, and then you reapply in the match the next year. So just because you don't match doesn't mean like you can't be a doctor. Like there's still ways. You just might end up somewhere that you didn't even know existed to know to apply there.
I was wondering if you could talk a little bit about what the UK College of Medicine looks like being on NKU's campus.
Sure. So we are about halfway into building our full student body. So right now we have first and second years. We'll add another class in the late summer. So we'll be at full capacity the summer of 22 when we enter that next first year class. And our first graduates will be in 2023. So what we're seeing nationally and locally is that medical schools need to produce more physicians for their state. So there's still quite a need for physicians in the state of Kentucky. So UK wanted to increase their class size. So when I went to med school, there were 100 in my class, and they moved that number up to like 130, I think. But then they became very landlocked. They don't really have space clinically and just physical space to have more students than that. So this is where regional campuses come in. So basically, you're still part of the same College of Medicine. It is one College of Medicine. There's just different regional campuses. So Bowling Green is actually 1 year ahead of Northern Kentucky. So they'll graduate their first class in 2022. And the partnership there is with Western Kentucky University and Med Center. So basically, it allowed them to increase their class size by 30 in Bowling Green and 35 in Northern Kentucky. So increasing a class size without putting more stress on the Lexington campus. I think regional campuses are really a great opportunity to have a more intimate kind of med school experience because your class size is smaller and it's more kind of community attendings. But you still have the benefit of having kind of everything coming from Lexington. So all the curriculum comes from Lexington. So even pre-COVID and everybody Zooming, like lectures get Zoomed from Lexington. So that everybody's having the same experience from the didactic standpoint. And I think a lot of people, especially, tuition costs for school in general have just continued to rise. So we actually see a lot of our students up here still living at home to try to save money, which has some kind of boundary writing. So you kind of have to make sure your parents understand that there's some different rules once you're in med school in terms of studying. But I think a lot of folks have enjoyed that support as well. So instead of like, I moved to a new city by myself, I knew no one. I had been in Lexington like once in my life when I moved there from Murray. So I imagine there's some comfort in still having, like some home cooked meals or someone to just sit with you instead of kind of coming home to your empty apartment. I'm not sure if you guys will hear about this as you're kind of going through your education, but the University of Kentucky has early assurance programs. It's called EAP. I think every college in Kentucky has a partner with one of the regional campuses. So UK only pairs with the UK honors program, but all the other colleges have a partnership with UK where sophomores in college can apply to the early assurance plan. And it's kind of committing to say you want to go to med school. They provide some practice interviews, they provide some MCAT support, but also you're kind of guaranteed interviews as long as you meet like the grade requirements and MCAT requirements. you basically get to enter with the early decision pool in terms of interviewing. So it really can increase your chances of procuring a med school spot. So if you guys hear about those as you're looking at colleges, or you can just look up early assurance and it'll tell you which schools are paired with which campuses, but it's very geographical. So we're paired with kind of the 10 colleges that are up by us, where Western is kind of paired with the Western side of the state. So how is nursing similar and different from med school? So nursing school is a little different than medical school, because your nursing school is going to be part of your undergrad experience. I think the benefit of nursing school is that you can kind of be out working if you want to pursue an advanced degree, like as a nurse practitioner. You can work as a nurse kind of first, and then you can do NP school, almost like a graduate program, more traditionally, where med school, you're not allowed to work while you're in med school, and you're a defined cohort. So like you start and you finish 4 years later. There's not a lot of flexibility in that regard. The other thing is there's no required residency after DNP or after nursing school. You'll do your role transition from nursing school, but there's no like residency or kind of that apprenticeship piece that's required. Being a nurse practitioner and being a physician, the training is definitely different, and our scope of practice varies a little bit. So in general, the DNPs have a little more kind of protocol driven care. And many of them, there's a little more like on the job training. So once you're done with DNP school, you won't necessarily have a specialty. You'll have your DNP, and then basically you'll kind of do some on the job. Like let's say your first job is with GI. So they will spend probably about 6 months training you so that you're kind of have been taught exactly what to do with GI. But if we move that then DNP to like urology, they won't really have a background. They'll have to kind of start over in terms of relearning that apprenticeship. Or the idea, for like, let's say internal medicine, is that I can take care of a lot of GI and a lot of urology and a lot of this before I have to refer them on to the specialists. DNPs can also be primary care providers. So I do have 2 nurse practitioners who work in my office, and they practice independently, but with collaboration. So, I still co-sign charts, and they'll call me even on days I'm not in the office to run things by me, say, hey, can you look at this? Hey, will you come in the room? What would you do next? So it's a little bit different in terms of what we do and how we get there. But there's definitely a place for both professions to work together as part of the healthcare team. Nursing is definitely a little more hands-on during undergrad compared to medical school. We hang out in the books a little longer.
The great thing is next week we have our graduate nursing program coming to talk about what our programs look like at NKU. And so talking about that, you've got your advanced degree for if you want to become a doctor, and you've got your advanced degree if you want to further your nursing career, which you can all do at NKU, which is great. All right, don't be shy, y'all. If you have more questions, you can also unmute yourself.
I think one thing that sometimes we think about as we're kind of going through college and med school is like about families. And it is very common and kind of in this day and age for med students to have children either before going to med school or during med school, and same thing during residency. I think 25 years ago, male students' wives would have babies, but the female students, it kind of wasn't a thing. It happened, but it kind of wasn't a thing, where I feel like it's more and more the norm as we've kind of equalized the number of women and men in med school. Actually, our current first year class at Northern Kentucky campus is like 66% women. Usually we're pretty even, but the way the alternate list worked out, like we ended up with more girls than boys. But definitely, like, I remember when I was pregnant with my oldest, like I told my mom, and she's like, what are you going to do about residency? I'm like, it's a job. I'm going to take maternity leave just like everyone else. So I think there's still sometimes is that like, you can't start your family till you're done. And that isn't true. I think medicine has become more family friendly as time has gone on, and there's more and more women in medicine. So there's a question. So how heavy was the course load in med school? Med school is tough. There's definitely a learning curve on how to study and how to manage that much information. The good news is there's lots of support to help you like learn those skills. But when you're in med school, if I'm being very honest, there's a lot of things you're going to miss out on that you're going to see your friends doing who are done with college and have jobs, or who, you know, are in grad school for engineering or that sort of thing, which is where most of my friends were. Basically, studying is your job and school is school. So there's definitely ebbs and flows based on the course and based on when your exams are. So like the weekend after exams, we very much felt like normal humans, you know, but then the next 10 days, as you were learning new material and studying for that next exam, you know, you didn't feel quite as human. And you definitely, you know, we encourage our students to practice wellness. So still exercise, still talk to your friends, still walk your dog, you know, that sort of thing. But there's definitely times, like I remember putting myself in what I called solitary. So if I knew I was struggling with material, I'd go to the book stacks in the library's basement where there were no windows and no people. So no one would walk by and chat. You know, I put myself in solitary so that I could, you know, try to master material I knew I was struggling with. And I think that's one of the hardest things for our students is, you know, being able to turn off all the other stuff. So like not clicking over on your laptop to look at social media and putting your phone on, do not disturb, you know, for big chunks of study time, because every time you're distracted, it takes so long to get refocused that it becomes tough with the amount of volume of material during medical school. I think for me, the best part of med school was it's really just those first 2 years that are like that. Because after that, we do clinical work. So 3rd and 4th year, there's still tests, but it's kind of based on your clinical experiences. So the first 2 years is a lot of like living in the books, and then 3rd and 4th years, kind of that apprenticeship. So, you know, you're on your core clerkships, you're doing your medicine, you know, 2 months, you're doing your surgery 2 months. You get to kind of practice a little bit of everything and see what they do and learn kind of that big foundation of what you're going to need to know to pick which residency and know where you want to go next. So I always kid that, you know, med school is a little bit like drinking out of the fire hydrant. There's a lot, but it's definitely doable. And I loved med school. I didn't love anatomy. Memorizing stuff was really hard for this engineer who only had to ever memorize the sum of all forces equals 0. So anatomy was a little bit of an adjustment for me. But I really I would rather go back and do med school again than like 6th grade.
One of the things that the students have seen in some of our past presentations is the simulation center at NKU. Does the College of Medicine take advantage of using our simulation center, or do you have some of your own simulation center space?
So simulation is something that we hope to continue to take advantage of. We actually have access to STech as well, which is the St. Elizabeth Center out on Olympic Avenue, as well as the Health Innovations. So more of our Sim Center time will actually be spent during 3rd year. So I don't exactly know what that's going to look like. We have our own Recessa Annie, who's like the mannequin for resuscitation. We just got her, like she came in boxes, and they're coming to train us on how to use her. So simulation was not a thing 25 years ago when I was in med school. Like we practiced on real people. I'm like, hi, I'm Meredith. I've never done a blood draw. I'm here to draw your blood. And that's how we learned. Where now, you know, you can put IVs in Annie, you can draw blood, you can give vaccines in Annie's thigh. We can practice intubations, we can practice codes, like everything that we just did on real people. The simulation center is great. So, you know, Lucinda's our like birthing simulator, so she can have babies. I think she has twins. She can simulate what we call atony, so kind of hemorrhage after. And so the simulation advances are huge. The other thing that's very different from when I was in medical school is like with the advent of handheld ultrasound, our students are actually learning ultrasound and some of the radiology stuff during anatomy. So not only are you kind of looking at the anatomy on the cadaver, you're ultrasounding each other, to look at like, there's your carotid. This is what it looks like on the ultrasound. And here's the MRI showing the carotids, MRAs. So that piece of it, I think, is also very different. And again, like the simulation center helps us with a lot of that. Like, so how do I put in a feeding tube? How do I intubate? Instead of just your first stab was always on people. And now you can do it on the simulator, which is great.
Yeah, it's nice to get in that practice before you're working on like an actual person who can yell at you. And
I just think back to like all those people who said like, yes, you can come in. Yes, you can learn with me. Like what a gift it was for kind of every patient that let me, have a piece of their journey.
All right, team. Are there any other questions? Feel free to keep asking questions. I am going to go ahead and start dropping in that student evaluation, teacher evaluation, and the student interest form, but you can wait until the end.
So how much more can a physician do than a nurse practitioner? This is kind of a tough question in the sense that, there's a lot of overlap, but like as a nurse practitioner, you're never going to be doing like surgery alone. And you're always going to have at least a collaborating physician, even though in most states you can practice independently, there's still a collaboration agreement. There's some medicines state to state that nurse practitioners can't prescribe. And the nurse practitioner DEA, which is your kind of drug license, looks a little bit different. So like the nurse practitioners who work with me can't prescribe ADHD medicine. So they can still do the visit and then they send the chart to me and I take care of that piece of it. In general, I feel like the nurse practitioners of our team do a little bit more of the bread and butter and things that are more predictable. So kind of fit more nicely in the nursing protocol kind of box. So I think that the physicians do a little bit more like of the problem solving or the perplexing cases, or initial workups where our nurse practitioners on our team might do some of the follow-ups where we're kind of checking in to make sure things are going well, but kind of the initial diagnosis and treatment plan has already been kind of handled. The training is a little bit different in terms of like kind of how we're taught to think and how we problem solve. So I would not ever say that they're the same, but there's definite benefits to both. I think our nurse practitioners do a great job with education. I think that's where nursing, really has a great foundation in kind of teaching patients and doing patient education. And so, I think that's one of the roles that follows through to our DMPs is, doing that new diabetes education, sitting down and spending, time figuring out like, what can we do to make this better? Because what we're doing isn't working. So like socially and like big picture with the patient, what else can we do to help? What else can I teach you to help you understand? And that's where I think that, thinking of it as a healthcare team is so helpful, because there's things that they're better at than I am, and there's things that I need to do that they can't. And like our kind of fund of knowledge, so all of those, hours spent during medical school, like that's kind of what we're built on. So often, we'll be able to say, this is some weird, wacky rash that, no one's seen, but I saw it in a book 20 years ago, where they would just be like, wow, that's a rash. I don't even know, where I'm pulling something like deep from the depths of my, books back in med school. I think that there's a little more investment in medical school. And that's why we see kind of reimbursement also being a little bit higher for physicians. Again, more complexity, more education in our back pocket. But they're not super far apart. So I encourage people, like, if you think you want to be, like, if you're not sure, really look at what you think you want to do in college. If you're like, I really want to do nursing, then probably nursing and DMP down the road is the way to go. I think most of our DMPs are most successful when they've had some clinical nursing experience and don't just go straight through. Where if you're like, I really love Japanese economics, but I want to be a doctor, then major in Japanese economics, do your prereqs and go to medical school. And we had a Japanese econ major in my class. We had pharmacists, we had lawyers, we had 10 engineers, pretty much you name it, we had it in terms of majors. So, you know, really still follow your kind of heart in terms of what makes you happy. You know, what do you want to study? You know, if you want to do broadcast journalism, that's cool. Do broadcast journalism. You're going to have a lot of, you know, med school prereqs that your friends aren't taking in broadcast journalism, but it's definitely doable. So do what you love. And if you're called, you know, to nursing, then that's the way to go, knowing that you can get your DMP. Where if you're like I don't really do super well with bodily fluids, like don't really like vomit, don't really like mucus. I don't think I could ever be a nurse. Those folks are amazing.
Yeah, that's one thing we really try to do with our early programs, you know, is to let folks know that there are bodily fluids involved in this profession, in this field. And it's good to know early that that's not something that you want to do.
Not that I totally avoid it, but, you know, the poor nurses, like really, and especially during residency when I was in the hospital, but really those nurses are like, there are eyes, I call them the eyes in the sky, but really there are eyes on the ground. Like they know that patient moment to moment, and they know when to say something's not right. You know, I need you to come look. They're not right. And so I think that's one of the most important things we learned in residency is if their nurse calls you and says something's off, like that's you listening to that bat signal to come down and start looking for what's going on. You know, you never would want to like blow them off because, you know, they know those patients, especially those babies in the NICU who can't talk to you, like they know when something's up. And so that relationship, you know, between nursing and patients is really amazing. And especially some of our like ICU nurses, you know, they're floating catheters and swans and, you know, doing pressures and all sorts of stuff that gives us great information that, you know, there are really our early warning system. So their job is hugely important. So I think it kind of comes down to reflecting kind of where you see yourself and where your heart is in terms of being at the bedside, you know, versus being more kind of the brain trying to figure it out when folks tell you like something's off.
All right, folks. If you have more questions, please drop them in. One other thing that I did want to preview is you all know we've been mostly closed on campus, but we are doing an interactive session with a program called Remake Learning Days. If you just Google that, I'll actually drop a link in because I was just starting to work on some stuff with it. They're doing all sorts of programming throughout the weekend of May 15th through the 17th. And we are doing a program in our simulation center. And it's a patient case about a patient named Billy who is having some issues. And there will be an interactive component where you get to tell us what you think our ER EMT should be to handle the situation. So it should be really fun, exciting. That's on May 15th, something to check out, but also look at some of the other really awesome programs. Looks like there's like at least 50 different programs going on that weekend for all ages. So please feel free to share with your networks. If there are no other questions, I would really like to have all of us thank our presenter. And then also to say thank you to all of you for showing up on this cloudy day. To engage in health careers and STEM. And hopefully we will see you next week.
Thank you.
Thank you.
All right, thank you all. Lots of love in the comments. All right, have a good day, everyone.